My name is Ben McNaughton. I'm a consultant paediatrician here in Belfast. I have a special interest in respiratory medicine, but I'm presenting today on status epilepticus. So very much from a general paediatric hat on, as opposed to a neurologist's opinion on it. So what is status epilepticus? Well, the International League Against Epilepsy is not, as it sounds, a superhero organization set up to rival the Avengers, but rather it's an organization which is devised and funded really to share educational resources and learning around for parents, patients, carers, and the wider sort of government policies and public education around epilepsy. And they define status epilepticus as a condition resulting from either a failure of the mechanism responsible for seizure termination or from the initiation of mechanisms which lead to abnormally prolonged seizures. And their time point that they use is 5 minutes. So why is the 5 minutes significant? Well, that's because we know that 90% of seizures under 5 minutes will terminate spontaneously without any medical intervention. However, if you continue to seize after 5 minutes, there's a 70 to 80% chance that you will be continuing to seize without any intervention by 30 minutes. And that's important because that 30-minute time point is the point where the risk of significant ongoing morbidity and mortality increases. Why include a talk on status epilepticus in a program like today's? Well, there's three main reasons. The first is that it's common. It's the most common medical pediatric neurological emergency. And for those of us who work in general pediatrics, pediatric ED, adult EDs, anesthetics, PICU, it's something which we're going to see on a relatively frequent basis throughout our career. The incidence is estimated to be about 20 per 100,000 children in the developed world. The second reason is that whilst it's common, it has potential to carry significant morbidity and mortality. It can be fatal. Now, thankfully, there are less deaths in children from status epilepticus than adults. However, the major concern is morbidity and mortality that can result from prolonged seizure episodes, and that can be development of epilepsy to ongoing significant neurological insults and sequelae. Therefore, it is important that we know how to treat it effectively and in an efficient and timely manner. The third reason is that actually it's an interesting area in terms of the guidelines, because the guidelines have changed over the last few years based on recent evidence. So it's important that we review these and recognize that we're practicing up-to-date medicine. One of the biggest determinants in terms of outcome is actually the underlying etiology or the cause for the seizure in the first instance. And the International League Against Epilepsy broadly divide these causes into two categories. The first are known causes or symptomatic causes, and the second are the unknown or cryptogenic causes. Known causes are further delineated into 6 main categories. So structural, that could be things such as cerebrovascular insults, space-occupying lesions, etc. Infectious causes, such as meningitis or encephalitis, TB, cerebral malaria. Metabolic causes, so some are mitochondrial disorders or metabolic disturbances. Toxicity and drug-induced, now that can be toxicity and drug-induced seizures as a result of illicit or prohibited substances, but can also be from sort of overdose or underdosing of prescribed anti-epileptic medications, for example, or other medications which affect the central nervous system. Inflammatory causes include the autoimmune conditions, some neurocutaneous syndromes, and then genetic causes. There's a wide range, but things like Dravet's, Fragile X, etc., can cause seizures. And it's really important to have an idea of the underlying cause as well as while we're working through the seizure algorithm. ALSG is the Advanced Life Support Group, and they are responsible for running the APLS, the Advanced Pediatric Life Support courses. They also are responsible for publishing internationally recognized guidelines on the management of common pediatric emergencies. And this guidance is endorsed by the Royal College of Pediatrics and Child Health. The first manual came out in 1997, and since then it's been reviewed at least on a 5-yearly cycle. This is the most recent edition, the 7th edition. And as I mentioned, the guidance, the guidelines on management of status epilepticus have changed over the last 2 years based on recent evidence. So it is really important that we're aware of what these changes are. Talk through them. I'm going to use a case-based scenario. So picture the scene: pediatric registrar in a district general hospital. It's 8 a.m. It is November, as it is now. It's the middle of bronchiolitis season. You've had a busy night clerking in countless numbers of children with bronchiolitis. You're ready for some tea, toast, and to get handed over and get out of the building when you get a standby call to resus. You arrive in the resus department, and there's an emergency department registrar and a pediatric SHO who accompany you. And the nursing sister gives you the basic information that was provided from the paramedics. They've got a 4-year-old girl. She's got a background of complex neurodisability and epilepsy. She had a prolonged generalized tonic-clonic seizure that morning. Parents have buccal midazolam from her history at home, and they give her an appropriate dose after 5 minutes. And the paramedics arrived really quite quickly, and within about 5 minutes later had her administered a second dose of benzodiazepine in the form of rectal diazepam at the appropriate dose. Their estimated time of arrival is 2 minutes, and the paramedics have informed you that there's ongoing general tonic-clonic seizure activity. You've got a couple of minutes, and how you use those minutes is really up to you, but it's important to think about how you maximize the time effectively. One of the ways in which we might want to do this is to allocate roles within the team, calculating wet flag calculations, and preempting what drugs or medications that you anticipate you might need if this seizure is ongoing. It's also worth taking a minute or two to consider the key aims of managing a child who presents with status epilepticus. The first of those is to support the airway, breathing, and circulation. The second is to identify and to treat any potentially life-threatening causes. And the third is to terminate the seizure in a timely manner, and in doing so to try and prevent reoccurrence, reduce the risk of long-term morbidity and mortality, and also reduce the need for intensive care admission. Whilst it's important that you treat the seizure rapidly, the approach to a child presenting with status epilepticus is the same as the approach to any resuscitation of a critically unwell child. It's important to get a brief history of the child, of what's happened, and an understanding of medication administered to date and any regular medication. And in this situation, it's also important to check whether with parents or carers or the paramedics, whoever's with the child, if they know if this child has an individualized seizure plan. As some of these children will have their own seizure plans, so that's important to check. It's also important to do a quick, focused physical examination to look for any obvious or potentially life-threatening causes. And then it's a case of working out and treating and assessing your airway, breathing, and circulation, whilst also not delaying too long before treating your the seizure itself. Airway, the goal here really is to maintain the airway and manage secretions. And in this case, the child presents, she has ongoing generalized tonic-clonic activity. Her airway is easily maintained with basic airway opening maneuvers, and there's minimal oral secretions. She suctioned once and they seem to have settled. From a breathing point of view, as with vast majority of pediatric emergencies, apply high flow oxygen, and you need to assess, do they need any support with the breathing? Do they look like they're breathing effectively through the seizure, or are they apneic, or would they benefit from any PEEP? In this case, we apply 15 litres of oxygen, but we're happy that we don't need to provide any further support at this stage. The third is circulation. We want to assess heart rate, capillary refill time, blood pressure, and get an idea of the hemodynamic status. It's also important to get early IV or IO access. And while we're doing that, if you can get IV and get some bloods away. Bloods, in this case, you want to be thinking ahead about potential causes. So an FBP, really useful. Hemoglobin, if it's low, may suggest an intracranial bleed. Platelets to check clotting, and white cells looking for infection. CRP will also be useful for infection and inflammation. Want to check electrolytes, calcium, magnesium, looking for any potential electrolyte disturbances which may be causing it. DEFG, don't ever forget glucose, and particularly important in the case of a child who's seizing. culture if they're febrile, and also thinking about metabolic causes if you can't get pneumonia and a lactate. And in this case, the patient is hemodynamically stable. There's a mild metabolic acidosis on their gas, and CO2 is the upper limit of normal, but within the upper limit or normal limits. Disability assessment, we want to look at their pupils and whether they're responsible to alert or whether they're alert or whether they're responsive to voice, pain, or unresponsive. You completed your assessment as such, and now we're 5 minutes post, or over 5 minutes since the paramedics had administered the rectal diazepam. You feel that you need to give another anti-seizure medication. I'm keen for you to tell me through the Slido app what you think would be the obvious next choice. Would you give IV lorazepam? Would you give IV levetiracetam? Or would you give IV phenytoin? And I'll give you a few minutes, a few seconds, just to get a few responses in. Call it there. We've got about 55% for IV levetiracetam, 40%ish for IV lorazepam, and IV phenytoin. So IV levetiracetam was the most popular, and that's would be in keeping with the current guidance. The concern, I suppose, for 40% did suggest potentially going for a dose of IV lorazepam. It's important to note that the benzodiazepines do remain our first anti-seizure medication of choice. And there's a couple of reasons why, and that's one, that they can be given quickly, and they also have a rapid onset. There are a number of options in terms of benzodiazepines included in the guidance, so IV lorazepam, buccal midazolam, rectal diazepam. There's some evidence to suggest that the IV lorazepam and buccal midazolam work better than rectal diazepam. However, your choice will largely depend, I guess, on what's available, what setting you're in. If you're in a pre-hospital setting, buccal midazolam or rectal diazepam may be more readily accessible than IV lorazepam. One of the big changes in the recent guidelines is the timing as well of the second dose of benzodiazepine, and we used to be after it was the second dose is 10 minutes after the first, but it's now 5 minutes after the first benzodiazepine. And you'll see that it is common practice to give a second dose of benzodiazepines. It's interesting though, because there's not actually a lot of evidence to support that. And I think part of the reason why that is still within the guidelines is that actually it's recognized that it can take time to gain access, and actually giving a second dose of benzodiazepine is important while you're waiting for IV access for some of your second line agents. However, in this case, if the patient has already received buccal midazolam with parents and rectal diazepam with paramedics, and we need to be very, very cautious about using more than 2 doses of benzodiazepine, because the risk of respiratory depression significantly increases. So in this case, I'd be avoiding giving a further dose of benzodiazepine because they have received 2 doses already. So levetiracetam was the most popular choice in the poll, and that would fit with the current guidance. And that's really another recent change in the guidelines, and results really from 2 large randomized controlled trials, Concept and the Eclipse study, where it was shown to be of comparable efficacy with phenytoin, which was our traditional next step in the algorithm. But why, if it's comparable efficacy, do we make the change if it's only as effective? Well, I suppose there's a few advantages to the use of levetiracetam. One is that it can be given to any convulsant child really without any contraindications. There's not concerns about whether the child could previously be on phenytoin, and do you need to adjust based on that. If a child's on Keppra, they could get more levetiracetam. It's also can be given in a timely manner, and it's given over a shorter period of time. So it only can be given over 5 minutes as opposed to a phenytoin infusion, which is 20 minutes. And it does not need any specific monitoring. The other thing is that there tends to be fewer side effects, and children tend to be tolerated better from a hemodynamic perspective. So although it's comparable efficacy to phenytoin, there are a number of potential benefits, and it has become our mainline second choice after benzodiazepines. So we're now 10 minutes after the completion of the levetiracetam infusion. Unfortunately, there's been no significant change in the overall hemodynamic status of the child, and she continues to have generalized tonic-clonic activity. You have when you started giving the levetiracetam, you also called for the anaesthetic reg to attend because you were concerned that that if they didn't respond, they may need intubation and rapid sequence induction. The anaesthetic reg is adult trained that is doing a pediatric placement and has never intubated the child before. Their consultant is on their way in, but is 5 minutes away. And I want you to tell me at this stage what you think the most appropriate next step would be. Would you proceed immediately to rapid sequence induction, or would you administer a further second-line anti-seizure agent, such as phenytoin or phenobarbital? I'll give you a few seconds to put that in the slide. Okay, I think it's probably reasonable to move on. We're getting about a 75-25% split in preference of a second-line anti-seizure agent. And that's right, I think. And the reason I say I think is that the guidance on this is actually very vague. And there's no real clear guidance as to what the next best step is. I suppose that the caveat in the guidance is really, are the team ready to proceed to rapid sequence induction? And that means physically ready in terms of having the equipment ready and to hand, but also the right people there. And do you feel that you've got time to delay that by whatever's needed? Now, I suppose this again is a change in the most recent guidelines. And it's largely based on some evidence from the concept trial, which suggested that actually by giving a second anti-seizure medication, you can reduce the risk of proceeding to rapid sequence induction by 50%. But the trade-off is that you will potentially delay then rapid sequence induction if you're given the phenytoin, for example, time to work by up to 20 minutes. And it's whether that's the right thing to do. And I think there is some uncertainty as regards this. And I think a lot of it will come down to confidence and of the staff who are present at the time. Your two options, should you choose to give a second anti-seizure medication, are phenytoin and phenobarbital. Phenytoin is generally what we'd recommend if the child is not already on phenytoin, but if they are, then phenobarbital would be the next option. It is important that these things to bear in mind that at each stage, start preparing for the next stage. Preparing for an RSI takes time. Preparing phenytoin takes time. So as soon as you're given the levetiracetam, you want to be thinking about the next stage. Okay, so in the last slide, you wanted to give the second line anti-epileptic. We've done that. And unfortunately, we're in a situation where we're still, the child is still seizing. And we've made the decision that actually we're going to need to go for rapid sequence induction to try and terminate the seizure. And at this point, then I want you to decide and tell me which induction agent would you choose for the rapid sequence induction. And your three options are thiopental, ketamine, and propofol. Okay, we've kind of got neck and neck there with thiopental and ketamine. Ketamine just slightly overtaken, and propofol is sort of a definite third out of those three. But ketamine. So again, this is an area where there's been a bit of a shift in terms of the guidance. Traditionally, the APLS algorithms were very much in favor of thiopental. However, the latest guidance suggests ketamine or propofol or thiopental. Not particularly helpful. There is a definite sort of preference in the guideline towards the use of ketamine. And the reason for that, I suppose, is due to that it can be used in children who are hemodynamically unstable with less risk of hemodynamic compromise. And that's the reason why it is most likely the most sort of commonly recommended now. However, that doesn't actually reflect the practice in a lot of units. And I know, chatting to the guys in ICU and preparing for today's talk here in Belfast, whilst it's potentially better if you're hemodynamic, there's hemodynamic instability, a lot of these patients aren't actually hemodynamically unstable, and they feel that thiopental or propofol would actually work better in terms of the effect of terminating the seizure. So it might be worth a discussion with the panel later, but this is not something which is very clear cut. And I think actually within our hospital, we're not sort of completely sold on the move towards ketamine in all situations, the first line agent. Just want to throw in there about paraldehyde, because I know some of us from a certain generation like paraldehyde. We've seen it used when it used to be more prominent in the guidance, and it seems to work. The guidance at the minute is really suggesting that it shouldn't delay giving a second line anti-seizure medication. So it's worth considering if you're struggling with IV or IO access, or if the child has it mentioned on a specific seizure plan. The guidance at the minute doesn't routinely suggest using it. But again, if you're in a situation where you're struggling, it may be something to consider, but it's not routinely included in the guidance. You've used your ketamine, your rapid sequence induction, the patient has, you think, stopped seizing. Just on this stage to think about some other investigations you might want to consider. One is neuroimaging or CT scan. And not everybody who comes in seizing needs a CT scan, but there are some indications where it would be, you'd have a lower threshold for doing it. One would be if there'd been any sort of trauma or you're suspicious of non-accidental injury. Second would be if you've got a focal onset to the start of the seizure, and that's where history is important. The third would be if you've got a VP shunt in situ. So they're all reasons why you may want to consider a CT scan. You may also want to think about lumbar puncture, toxicology, metabolic investigations, anti-seizure medication levels, and an EEG, depending, if you go back to the causes we talked about at the start, depending on what you think are the most likely causes. But it's also important to consider, just because you've anesthetized and you've carried out rapid sequence induction, have you actually stopped the seizure? How do you know? And again, this is something that might be worth a panel discussion. How do you know they've stopped seizing, and what if they haven't? Other points we thought would be important to mention is that muscle relaxants are not really, we recommend avoiding the use of muscle relaxants. And also, generally, our advice from the ICU team here would be not to worry about switching from a nasal tube or certain arterial lines. A lot of these children, when they're transferred to ICU, are woken up really very quickly following admission to the unit, and don't need such invasive care. And I suppose then that really raises the question of, can you actually extubate in the district general? Does the child, after the seizure stop, need to come to PICU? And another shameless plug for a previous pro-con debate that we had during our last Paediatric Emergencies Day, which is available on YouTube, where Gail and Ben discussed this very topic. Should children with status epilepticus be extubated in the GGH? So it's something to look at for further reading. So key learning points. I suppose step one, step two, there has been some changes in the guidance with shorter 5-minute interval between the benzodiazepine doses. And it is important to mention that pre-hospital treatment is endorsed, but should be taken into consideration in regards to choices about further medication. With regards to step three, the second line drug of choice is now levetiracetam, which is a change from phenytoin. Step four, if the team are ready, you may want to proceed to RSI with propofol, thiopental, or ketamine. But if not, it's reasonable in certain circumstances to give a second line anti-epileptic and prepare for RSI. Thank you, and I'm happy to take any questions.
There was a question that came up about if the seizure stops, and I think this will have to go to the group as well, but if the seizure stops, so you've given 2 doses of benzos, and then 4 hours later or 3 hours later, the child starts seizing again, do you restart the algorithm at the start again with your 2 doses of benzos?
It's a difficult question. I suppose it depends, how the child is. Are they back on the ward, back to normal? How they can sort of return to their normal self? They active, running around, or have they been quite sleepy, drowsy following that, or ended up proceeding down the algorithm to sort of extensive sort of second line agents? I would exercise caution with benzodiazepines if they've had them within sort of 4 hours before, so it is a difficult one, and I'm not sure what other people think, but I certainly don't know that I would be taking a double dose. You may want to give a smaller dose and titrate, slightly lower potentially, but I'm not sure.
From my perspective, I think you're right. You're potentially going to give them they're going to have respiratory compromise quicker if you double it up again. I do use paraldehyde as one of my anti-seizure medications, and if I haven't used that, I might potentially use paraldehyde and then move on to giving Keppra, because they've obviously had a seizure that was treated with benzos and it's still ongoing. So I'd probably load them with Keppra as well. Costas?
I'm exactly with Judah on this. I have a low threshold for loading with Keppra. Sometimes we even use it as a bridge to try and avoid intubation, even when phenytoin has been used as a Hail Mary if it's been given slightly earlier. But if we've loaded with benzos, there's been an hour or two where the child has recovered, hasn't had any seizures, is out of the post-ictal phase-ish, and then we need something else as a moderating factor before we load with Keppra, then paraldehyde is it can be a lifesaver, really. I really like it.
Peter?
Yeah, I was just going to say that, this all depends on the context of the patient. And, people worry about giving repeat doses of benzos in case it causes respiratory depression. Do you know what does cause respiratory depression? An RSI. So, in terms of context here, if the patient's had a couple of hours of being good, the worst thing for this child is to end up on a ventilator if they don't need to. Now, if you manage their seizures and they've got respiratory depression and they need that, then so be it, as long as you've managed the seizures. So I'm not saying that anyone else is wrong. It's very reasonable to think about other drugs, but I wouldn't be scared to use appropriate drugs if it's hours down the line. And actually, respiratory depression, you just have to accept that that's a sequelae of managing the seizures appropriately.
Yeah, I think I'd be tempted as well to give a single dose if it was a number of hours, like you say, 4 hours down the line, because they worked before and they terminated the seizures and it's recurred again. So it may well work, but I would probably caution giving 2 doses. But again, there's no actual guideline for you to follow. You're having to make up your own mind based on your own clinical judgment.
Yeah, and I think that's the thing. And then you can start over analysing how long is too long afterwards. And I suppose you can get into pharmacokinetics of benzodiazepines, but what about 6 hours? What about 8 hours? I think it's using your judgment based on how they've responded to it initially, their initial presentation, and where you are as well, and how equipped you are to deal with potential side effects and complications. So it's a good question because there's no definite answer to it. In terms of I wouldn't mind discussing the induction agents with guys from PICU, because new guidelines definitely sort of seem to push towards ketamine. I know Chris, certainly when we were chatting about it, wouldn't be your first line choice necessarily if they were hemodynamically stable.
You might have missed this, Ben. We did this during the questions from the DGH. So we had a good detailed discussion on this, and there was a bit of mixed feelings on it. But again, I think whatever's within your own normal routine and whatever you think is safe to do, and it's good that you now have a choice to include it if that's your preferred option. Probably the question that might be worth covering is, how do you tell the patient stop fitting? I think that was your other one, wasn't it?
Yeah, how do you tell they've stopped, and what do you do at that stage if it's still ongoing?
Yeah.
One of the questions is actually if you've paralyzed them because you've given them RSI, do you use CFAM? So that might come into this as well.
Yeah. So you're only really going to have CFAM by the time you get to the ICU, and the DGHs aren't going to have access to it. So it's how do you tell the kid to stop fitting? And I think it's the other signs that you're looking for. You're looking for the heart rate and the blood pressure to settle, and I think in particular the pupils are very helpful.
Which brings us full circle to my pet hate of atropine as a routine choice of drug for intubation, because obviously atropine causes meiosis, and then your pupils stop reacting, and then you lose a significant diagnostic tool before you arrive on PICU as to whether this child is fitting or not, because we rely on heart rate, blood pressure, pupils. And if you've taken, for me, possibly the most important one away because you wanted to use atropine, then you're blunting your diagnostic ability. And so that for me is a big no-no. So dilute adrenaline, especially if the child is a bit, shocked, is much better. If they're not shocked, then there might be a reason to use it. The only caveat is traumatic brain injury, where you don't want to get high blood pressure spikes, and there might be part of a Cushing's response when you're hypertensive. So then you would need probably to use atropine rather than adrenaline. That would be my only sort of caveat.
Yeah, Costas, I tend to use adrenaline in all circumstances, to be honest. I can't even remember the last time I used, atropine preferentially. I think, we need to be careful that if we are saying, or there's suggestions made that, we need sort of CFAM or EEG to make sure the seizures have stopped. If people start suggesting that, then it will absolutely move district general hospitals away from extubating these children before they end up being transferred to an ICU. And I think if these children present with a first seizure or need a workup for a seizure and it's unusual, then that's one thing. But if you've got a child with a known epilepsy and a known cause for seizures, and they present in status and they need to progress to an RSI, I think these are a group of patients that usually can be very safely extubated in a district general hospital and woke up and assessed clinically. So in that cohort, I wouldn't support the need to be transferred somewhere for EEG monitoring or CFAM.
The other important thing is Ben had mentioned avoiding muscle relaxant. That was after you've intubated the patient. Obviously, you're going to need muscle relaxant to put the tube in, but you shouldn't be topping this patient up with muscle relaxant. And I would normally muscle relax most ventilated patients for transferring them. The seizure patients, I don't tend to, because again, you've lost another one of your useful markers. I like them well sedated, but not muscle relaxed, so I can see if they start fitting.
I think the extubating locally policy is really taken off in many parts of the UK, to be honest. But there is an art to it. But essentially, if the child is more than 6 months, if there's no trauma and if the CT is normal, up to 3/4 of these patients can extubate locally, provided we haven't given too many benzos, we haven't kept them on a long-acting paralytic, and we haven't topped them up with opiates, all of which suppress breathing, obviously. But if you manage them with a bit of propofol on the background or gaseous anesthesia in the background, then all you have to do is switch the anesthetic off, and when they're ready to pull the tube out, they will tell you. Hyperventilate them a bit as well to retain CO2 to stimulate those baroreceptors. And 3 out of 4 patients like that would extubate. It empowers the GHs, I think, in a way.